Well, kia ora tātou, everybody. Bruce Harrell's my name. I'm the director of the Goodfellow Unit, Head of Department of General Practice and Primary Healthcare at Auckland University. I'd like to welcome you tonight. We've got over 500 people here, so it's impressive the amount of interest we've got. So we're working with the Northern Region Health Coordination Centre. We'll just use the term NRHCC tonight. They've sponsored this webinar, and they're coordinating the vaccination rollout program in Metro Auckland on behalf of the local DHBs and working in partnership with Primary Care Organisation. This is a very important webinar because we're at a critical stage of the vaccination program. This is, I think, the finest hour for primary care and pharmacy. This is where the action is going to happen from now on with the vaccine rollout. So tonight we want to acknowledge primary care's substantial contribution to the program and talk about where we've got to and how you can continually proactively encourage and support vaccination in the next steps. So we've got some really good speakers tonight, including Jess Berentson-Shaw, who's going to talk to you and answer questions about how to talk to patients about COVID vaccinations and build their trust, because in primary care, we're trading on our trust for the patients. And my experience is that we can, with that trust, they will listen to us much more so than perhaps strangers. We have a speaker from Whakaronga Aotearoa talking about how COVID vaccination in the Maori and Pacific Health Lines can support our discussions with Maori and Pacific patients. They're clearly a target group that we're needing to work with and help get vaccinated. And there'll also be updates from NRHCC team and one of the PHOs. So there'll be, as well as questions after Jess's presentation, there'll be a question and answer session at the end. We'll answer as many questions as possible as we can, and we'll collate them and provide written answers. And these will be added to Health Pathways as soon as possible. And there'll also be a Med-ins to let you know. So hopefully you're getting the Med-ins signals on a daily or regular basis. As you know, we're recording this webinar and we'll share this with you we'll share this with you afterwards and on Health Pathways. Remember, Health Pathways is an excellent source of education about COVID-19 in the program. As always, we really appreciate feedback. So there's a poll at the end of the webinar for this. So now I'd like to introduce Matt Hannant, who will provide an update on the COVID-19 vaccination project in Auckland Metro. Matt is the Vaccination Program Director for the Northern Regional Health Coordination Centre, that's the NRHCC. Matt was Director of Strategy and Transformation at the National Health Service in London and has a background in health economics and health policy. So welcome, Matt.
Kia ora, thanks, Bruce. And tēnā koutou katoa. And thanks everyone for your time tonight. I've just got a brief presentation to share, just to give a little bit of an overview about where we're at with the vaccination program in Metro Auckland. So yes, it's been amazing really where we've got to. So we are sitting at around 87% first dose coverage and 62% of people who are fully vaccinated. Just want to acknowledge the huge contribution that has been made through primary care during that period, with over 57% of all doses administered. And you can see the breakdown there across the two settings in pharmacy and in general practice. And a staggering 2 million doses administered through Auckland. We've now got over 320 vaccination sort of sites. That includes the big community vaccination centres, there's 16 of those, a number of GP clinics, a significant number of GP clinics, and actually more and more onboarding every day, and you'll hear a bit more about that later. 100 pharmacies, and again another 40 or 50 in the onboarding process there. We've got 2 big drive-throughs continuing to offer that choice to people. And then you'll have probably seen the Shop Bro buses and the camper vans that we launched on Monday. Monday. So there's really a significant number of access points for the community, and really now the opportunity just to walk in at most of those sites. All people can book if that's their preference, but there's a lot of capacity in the city. We're seeing a strong demand for vaccination at the moment, particularly with dose 2s coming forward. Thinking about that huge uptick that we had at the beginning of the current outbreak for dose 1s. And we're losing lots of multiple strategies really to target the unvaccinated population, with a particular focus on Māori, Pacific people and people living with disabilities. The data that we've got, that you'll probably have seen as well, is starting to show a real sort of leveling up across a number of age groups. Just a few weeks when we looked at these graphs, there's a very pronounced gradient down to the left as you went through the younger age groups. In the 12 to 15 age group, we've now vaccinated over 77% of that group have had a first dose, and actually primary care has been an enormously popular setting for that younger age group as well, which has been really sort of heartening to see, given they've only just really recently come into the eligibility piece. We are seeing really good levels of vaccination in the older communities, queer and Kaumātua, and decent levels, particularly around the equity. But we need to have that continued focus on rangatahi and younger people in the community, where we are seeing those inequalities persist. So that's really where we're focusing a lot of the current effort, really around those sort of 16 to 34-year-old groups, with a little bit of work to do around the 12 to 15-year-old groups as well. So the focus now for us really has sort of turned to those really highly targeted, tailored outreach activities led by Māori and Pacific providers, using the outreach buses, using the vaccination camper vans, focusing on homeless communities, people living in boarding houses, those really sort of vulnerable communities, sex workers and others who need sort of that special support and targeting. We have now made available things like free taxi and shuttle services for those with transportation and mobility issues. We've got in-home vaccination services as well, and we've seen strong demand for that, with over about 600 people seeking those services. And again, just acknowledging the amazing work that primary care general practice is doing there to support that. Again, another service that, and general practice, the point Bruce made around those trusted relationships, and really sort of ensuring that we're able to utilize that and the funding that's gone in there to have those conversations with unvaccinated Māori and Pacific people. People will have seen the Super Saturday that's coming up this Saturday. So that's really a huge kind of nationwide initiative to vaccinate over 100,000 people on the day. Lots and lots of stuff happening here, and just again acknowledging all those partners who will be open on that day and providing services. I think there's a big push to sort of make it a bit of a festival feel, the most that we can at level 3. There's going to be tons of resources available. There is additional funding that's going in to support those practices and providers that wouldn't normally open on the day as a sort of contribution, and really looking for support and ideas in that area. And I know that we've already hearing about some of the really exciting and great things that people are planning in terms of food and kai and sort of, you know, DJs and music and you know, costumes and such, like really sort of get people in the mood and drive up that demand. And the Vaxathon, that'll be a big part of that on the day as well, and lots of media coverage and such like. There's still a lot of work happening with the pop-up events, and people have seen the big event at the Vodafone Event Centre last weekend. It attracted a huge number of people to that, and a lot of targeted communications activity community. So a lot of work through social media, TikTok, influencers, and really sort of trying to do those events now to really reach in, and doing a lot of work with industry and business leaders who've provided their support and providing resources and investment into those areas as well. So yeah, just really wanted to acknowledge the huge amount of work that's gone on, echo Bruce's comments about really just that final push. We're so close to getting those really high levels of vaccination. We're seeing really great uptake on dose 2s. Just really got to focus on closing that equity gap, and just want to acknowledge and thank everyone's contribution to that, and look forward to a great day on Saturday. Thanks, Bruce.
Thank you, Matt. I just checked the weather forecast and that is looking pretty good for Saturday. So hopefully a bit of a festival there. So thanks very much. I'd like to introduce Dr. Jess Berentson-Shaw, who's going to share her tips on how to talk to patients about COVID-19 vaccinations and build their trust. Jess is a public narrative researcher, advisor and co-director of the workshop. She's also a senior research associate at the Public Policy Institute at the University of Auckland. And she recently produced a very helpful communications tip sheet for IMAC. So Jess will now present and then take some questions. Over to you, Jess.
Kia ora, thanks Bruce. I'm just going to share my screen, everyone. Kia ora, I'm talking to you from Whanganui-a-Tara, where we're luckily in lockdown too. So I just want to acknowledge all of those of you who are in higher levels and all the hard work that you're doing for us. We really appreciate it. I'm going to talk very briefly at some high level points today about our work in the COVID vaccination space, which we've been doing for a number of months now, and of which this is part of. Who am I and why do I talk about this stuff? I used to work in evidence-based medicine actually. In a previous life, I worked for both NICE and the New Zealand Guidelines Group actually, and came to this work because I realized that facts and great evidence don't always convince people of why they need to do things like getting vaccinated. And I was really interested in how it is, how we talk and communicate, and the words that we use and the ways in which we converse with people can really affect their thinking and their action. So that's what I do at the workshop with my colleague, Marianne Elliott. And a lot of the work that we've done in the COVID space has been supported by various people, including IMAC, but also we've done work with the Victorian government and their health department there. So I just want to acknowledge the various groups that have helped us do research in this space of how we can get people over the vaccination line. So really briefly, what I'm going to talk about in 10 minutes, which is a bit of a challenge for me, I'm a wordy person, will be some key insights from that conversation guide, connecting, not correcting, and our wider work on COVID-19 narratives. I want to provide some practical tips. We've got some flow charts and I'm just going to talk you through those. And then we'll hopefully have 10 minutes. I'm keeping an eye on my watch to answer some of your burning questions. So first thing that we know is assuming people are willing to get vaccinated is critical. There's a lot of talk out there about hesitancy, about concerns. There's a lot of focus in the media, certainly, on people who are refusing vaccination, but most people will get vaccinated. I know that most of you working in this space and in health know that vaccination is a normal behaviour that most of us engage in most of the time. So it's no different with COVID. We should keep that assumption there, and partly we should keep that assumption not only because it's true, because we want to keep normalizing vaccination as the healthy default behavior. Hesitations, why don't people automatically get vaccinated? They're multi-layered and complex, and as we just heard, access is still a primary driver. Trust is also a big issue in this space. So for populations who have experienced mistrust in the health system, then we'd certainly say that coming through. It's important not to assume that it's just false information that's driving people's concerns. And as I've said, getting vaccinated is this act of trust. It is built through relationship. It is built through reassurance and connection. And for many of you working in this space, you will be that trusted person. Some of you won't be, and I think it's important to acknowledge that for particularly people who have had negative experiences in the health system, or in fact the wider governmental system, you may represent someone who's not trusted. So it's important just to keep in mind that people may prefer to talk to people with a shared lived experience of them, or a member of their own community. So as much as you can, keep those people in mind and have people who you can refer people on to. If people do come to you with significant concerns, and you will certainly have people talking to you all the time about some of their concerns, then what we know from years of research, and I'm sure I'm not telling you anything that you don't already know, you're all experienced practitioners in this, is active listening is critical in this space. And we've got a little shorthand, ask, tell, ask. Actually, my colleague Jordan today said to me she felt that it should be ask, share, ask, which actually I do feel is probably more appropriate for the active listening. What we know from our own research that we've done with people is that while people might express concerns about the safety and the risks of the vaccination, leading your conversation with evidence around safety and risk isn't reassuring to them. What is reassuring is when we can lead with the reasons why a lot of us got into this work is because we care about people in our community. And we find that when we start our conversations with our care and our sense of responsibility and professionalism towards them and their health and our wider whānau and community's health, then it does reassure people. It gives them an opening at that point to hear your information about the safety of the vaccination. So that might start with, I'm just giving some examples here about why vaccination matters to you and why you care as a health professional. So some version of, and this is just obviously a suggestion, and you need to think about what works best for you and feels most authentic to you. I got vaccinated because I really care about keeping everyone in our community well, including you. And that is certainly something that we know many of you as health professionals feel. So it doesn't feel too far away from what your actual experience and values are. We do know that people may have quite a limited understanding of how health systems and vaccinations work. We do find that people have incredibly low understanding of immunity, and especially what we would call collective immunity. So that's our new description for herd immunity, because herd immunity is both a jargon term, but it's also been misused during the COVID pandemic. So we call it collective or community immunity. And you can help deepen people's understanding of immunity and how it works with simple language and effective metaphors. And I don't talk about them tonight, but there's certainly in the guide some ideas for what the research shows can really work. And really importantly, which comes through very strongly and you're in a great position to offer, is let people know you are very confident that vaccination is right for them. We do know that when health professionals and trusted people recommend vaccination, people are much more likely to get vaccinated. So that comes through very powerfully. So I just want to emphasize that. So I'm very quickly going to run through our various pathways. There actually should be 3 pathways, and I'll show you the 3rd pathway. But the first pathway is really that somebody consents to get vaccination without hesitation. It's very important to offer affirmation, and if possible, ask them to share their story with those people around them, because we know that vaccination is a social activity. People get vaccinated because they see other people they know and trust get vaccinated. So as much as you can encourage them to share, that's great. Path 2 is the person has some hesitations, and then we move on to listening and building trust. Now, it's important to know, people might not actually say outright, and you know this from your own experience, it might be body language that you need to read. People's concerns might not be expressed outwardly, and certainly there are different cultural expressions of concerns or hesitations. So you are best experienced to be able to read that. In which case we move into the active listening phase. And this is really about asking people initially how they feel, listening, being humble. There's a great quote from Sheila Jasanoff, who's a scientific philosopher, about one of our best technologies in health and science is the technology of humility. So really treating people as experts in their own life, asking them what they're concerned about. And at that point, you might then come back to reflect what you've heard, share your understanding of the evidence, and that's your opportunity as well to connect to them through your values. Talking about your sense of care and concern is certainly something that you can connect with people on. They will no doubt also express care and concern for their family and wider community. Even those people who we know actively decline vaccinations do so out of care for their community. So finding those points of connection is going to be really important. Again, fewer facts, more values, giving people information to take home or other trusted people they can talk to, explaining using jargon-free language and metaphors, and again, making that emphatic recommendation. Remembering that people might not make a decision right then and there, and that's okay. If you've made a connection with people, see that as a positive aspect. They may go away, consider it, talk to other people, as this is a long-term relationship. You know as much as anyone that this is very much about relationship building. Pressing a sense of urgency on people to get vaccinated who are hesitant, we know can backfire. So I would recommend that you don't press people in that space if they're still not sure. Rather, continue to provide support or awhi them in different ways as a health practitioner so they feel that they can come back to you. Now, a third pathway, less likely perhaps, but increasingly as our uptake for vaccinations get higher, you probably will encounter people who staunchly deny vaccines. We think it's somewhere around 3 to 5%, maybe up to 7%, we're not quite sure yet. You can listen again to build trust. Avoid facts offs. We know that counter presentations of facts to counter their often cherry-picked facts will lead people to bed down, to back them into a corner, creates a backfire effect. So a simple presentation of your understanding and your values. You can either choose at this point, and I just want to enable you really you can choose to engage in that values conversation I've just noted, or you can choose to end the conversation. I just want to kind of give you that freedom that sometimes ending the conversation and continuing to maintain a relationship and leaving the door open for later conversations is the best thing that you can do. We do know that once people are ideologically opposed to vaccinations, it can be very difficult to move them, and it will take a number of engagements across different people. So don't feel like choosing to end the conversation is some way a failure or you've failed people in that case. And finally, I just want to finish up with this. What we know from our research is that people are complex and contradictory. They're capable of holding many different views and ideas at one time. They come to you with concerns, and even they might be relatively far down the continuum of having hesitations. Most people are capable of shifting if we create the context in which people feel heard and supported. And finally, just if you want more information, as Bruce mentioned, there is our How to Talk About Vaccination Guide. We also have, for those of you who do professional communication, we have a guide for professional communicators. If you're working in DHBs or in your community and you want to do some more higher level communication. And this week or next week, we're about to put out a conversation guide, which is for family and whānau and how they can have some of these tricky conversations, which also might be something that's useful to hand on to some of the people you talk to.
There's one question that I think would be good. We've had concerns about fertility post-vaccine. What would you say to those families?
Yeah, so I think the first thing again is really to connect that it is normal to worry about that. If you're a family who's wanting to have a child, it's a very important thing. First of all, just really hear that, and that people's concerns are valid, and that is something that matters to them. And at that point, you'll be able to have a conversation about the good information that you have, that we know that that there is sufficient information to us, but for us to believe that the vaccinations are something that women and people are intending to have children should be taken.
One thing I've tried, and it's had some success so far, is saying to people, I beg you to get vaccinated. I really don't want to lose you. And I think that I remember Paul Gilbert, who's the compassion-focused therapy person, says sometimes compassion takes a bit of courage. It takes a bit of courage to say that, but I think that shows that you really care about this person. I mean, these
Absolutely.
people. What's your view on incentives, vouchers to vaccinate?
Yeah, there's mixed evidence on this, and certainly at COVID we don't have a lot of clarity. One of the problems that we've got with incentive systems is it potentially suggests to people that vaccinations aren't something that we would do without getting rewarded for doing it as a public good. And one of the challenges certainly that we've come across in our research is that vaccinations have traditionally been talked about very much in an individualized risk and benefit way, which is partly why people don't understand the role of collective immunity and the role of the kind of social role of vaccinations. Our concern is that incentives potentially further undermine the kind of social good. There is mixed evidence that in some groups, particularly, for example, drug users, people who use drugs, then some incentives might work for particular vaccines. We haven't seen a lot in a general vaccine rollout yet.
Okay, so how do we respond to patients who ask about GPs, a trusted source, who are against the vaccine?
It's tricky, and what we'd say, I can probably bring in evidence from the climate science here. Again, sometimes we'll talk about using something called a truth sandwich, which is we start with our values and what we know to be true. So we know that the vaccines are safe. We might say, look, the vast majority of healthcare practitioners know these to be safe. This is untrue information, and I recommend that you get vaccinated, and just really keep it in this, the truth, why we care, why this is untrue. These people have been misled or they've misinterpreted the information. I recommend you get vaccinated.
So I've got a couple of really good questions. We're running short of time, Jess, but one is, are there any videos of doctors and nurses doing this? Are there sort of worked examples?
Look, I can find some for you. I know that certainly internationally we have got some, and I have looked at it in the research, we have got some online training that talks about this type of motivational interviewing technique. So I can certainly find some and send them on.
And a great one from Barnett. He says, if you have a pregnant patient who's agreed to get vaccine, how do you feel about asking that patient to then talk to other people who are vaccine hesitant?
Absolutely. Absolutely do it. Yeah. We know that, as I said, getting vaccinated is very much a social activity. We get vaccinated when we see other people who we trust get vaccinated. We perceive as experts those people who share our lived experience. Other pregnant people are much more likely to see a pregnant person as an expert in vaccination. And so as much as we can get those people who represent the kind of lived experience of perhaps people who have hesitations, talking about why they got vaccinated and how they got over the vaccination line, very powerful.
Okay, Jess, well, we've run onto time there. So I'd just like to thank you very much. That was great.
Thanks, Bruce. Thanks all.
Okay. Our next speaker is Siobhan Trevallyan. Siobhan's a GP at the Waitakere Union Health Centre and the Youth Health Hub. She's been working hard on the vaccination program, and she's got a particular expertise in dealing with hard-to-reach Māori patients. So she's very keen to see all our people protected as quickly as possible. So Siobhan, welcome.
Kia ora everyone, thank you for having me tonight. Just a few quick comments about our experience as a vaccinating practice. We started the start of this lockdown when we had about 3,000 of our patients unvaccinated completely, and they're largely a high needs population, predominantly Māori and Pacific. The things that we've done in our practice which have helped engagement and driven up the vaccination rates have been a mix of mass reach outs using kind of 2 or 3 text outs to different cohorts within the unvaccinated group across each week, and targeting depending on what's in the media in terms of when we lowered the age, when we changed the gap between the vaccinations. What we have found has worked best as we're coming down into the tail of unvaccinated people. We've still got about 1,300 patients unvaccinated, and the thing that's changing them is really much more about individual contact. And facilitating vaccination anywhere, so not just with us. We don't need to hold these people to be vaccinated in our centre, we just want them vaccinated. But when we do vaccinate, we prefer to vaccinate the whole whānau, and we encourage them to come in whether they're registered or not. We found that those relationships that Jess was talking about before are really, really important. So if it's your patient and you know them well and you saw them 2 weeks ago and you had a really intense conversation, you're the right person to ring them. So I've had patients say to me, "You're the boss, doc, I'll get it done for you." Or, "You're my nurse, you know me, I'll do it, you did it." And those sorts of individual connections are really, really important. We've had a really high DNA rate in our bookings, and that's been quite hard and quite fatiguing for the staff. But we have just kept booking people. We've got one whānau that have booked 3 times, and I believe they're booked again tomorrow. And we're really hoping they show tomorrow. It'd be really good. If they don't, I think we'll be driving off to their house. We have done some home visiting, and that's worked really well as well. And I think, as Jess was saying, the really important thing is making those individual connections. So listening to the person, what their story is, respecting their views and being kind about it. It can be frustrating because we just want people to come in, but it doesn't work to get frustrated. So in terms of the system stuff that we've done to support our team, we have a morning huddle every day where we talk about the vaccination and allocate roles to everybody. Give active feedback, lots of graphs are put up, acknowledging the effort that everybody's doing, move the system around if we need to, get everybody involved, everyone's on the CIR, everyone can do this, and just that constant messaging that every vaccination counts, everyone is potentially a life saved. We've had a really high rate of COVID infections in patients in my practice, so we really know what this looks like and we don't like it. So just in summary there, the things that we've put in place that have worked really well is working with other practices, so taking vaccines over to the Youth Health Hub, getting the entire team in behind it. We've had really good support from our PHOs, so they've helped us in terms of the phoning out to patients, but also in provision of lists of people that are unvaccinated, people who've got bookings elsewhere that are 3 weeks out. So we've got target groups that we can get into. When a person books in, they get 2 text messages and a phone call before they turn up, and that's been really good as well because we know who's coming. We've changed our draw-out process a little bit, so it really is 1 vial at a time. And as I said, we're getting really good support from our PHO in terms of management and leadership support as well. What hasn't worked for us, and we learned this pretty quickly, is focusing on registered patients and our drive to get our patient group vaccinated with us. We need to vaccinate anybody that wants to be vaccinated, and that gives us resilience in our vaccine delivery. Working in isolation and not understanding what's going on out there in the community also doesn't work. We need to know if there's a shop robust around the corner or a mass vac centre at the Trust Stadium, so that we can direct people there. So when they're on the phone, changing their mind, we can send them down the road. And we've just found that just putting aside all of the claims and the recognition for good work and just getting on and doing the job and looking at our overall vaccine rates is really important, rather than worrying about how many we're actually giving on a day by day. So that's the stuff that's worked for us and hasn't worked for us, and I hope that's been really helpful. Thank you.
Siobhan, just one quick question from Eva.
Yeah.
How do you establish the patient still requiring vaccinations? Can you do a query builder?
So we can do a query builder based on the COVID vax notifications that we get coming through. There is a delay in that, so it can be up to 5 days before we get the message that they've been vaccinated somewhere else. We just say sorry to the patients if we've asked them and they've already been vaccinated. On the dashboard that our PHO provides, it does say COVID-1 was given on whatever date and when the next one's due. So we run a query builder, and then we do the text out, is how we've been doing it, and making sure that we're uploading those messages in that come in the NIR inbox before we do that. Yeah, I know we're not always going to get it right, and we've had some really grumpy patients that have had 12 text messages by now. We're just sucking that up basically and carrying on going.
Well, it's a sign you're trying hard, isn't it? I mean, I guess the patients have to accept that if you didn't care, you wouldn't be sending 12 texts.
Yeah, I might tell some of them that tomorrow. I think that's a great line. Thank you.
It's the flip side of it. You've got to reframe
Yeah.
it. Well, thank you, Siobhan. That's fabulous. Our next speaker is Sara Lewis, who's the practice manager at Kawau Bay. She's 13 years experience as a practice manager in general practice, as well as extensive experience in emergency services in the UK and New Zealand. And she's been involved in the National Change Management Program in both countries. So over to you, Sara.
Hi, thanks, Bruce. Right, before we started this, when we knew that we were going to vaccinate as a general practice, we wanted to have a think about our past experience. And during the measles outbreak a few years ago, we thought we'd done a great job communicating with the Pacific Island family about the need to self-isolate. And it was a family of 7. And we thought we'd done a really good job. And when we did the follow-up call the next day, we discovered that the entire family had gone back to school and back to work. So whilst we thought that we'd communicated well and got a message across, we realised that in fact we hadn't done as well as we thought. So when COVID hit, we wanted to make sure that with our Pacific community, which is quite unique where we are, that we were thinking carefully about what would work for them. In our area, we have a lot of rural growers, so we've got a significant number of Pacific who work for those particular growers. Predominantly, the community is from the Kiribati Islands, which is between New Zealand and Hawaii, but also a community from Vanuatu. So in context and looking at those communities, we wanted to have a think about who their key or comfortable relationships were. And we realized that in that case, their relationships really were with their employers, and they were most comfortable with other employees in that company and with their employers. So we felt that the best way to get these people vaccinated, which weren't our enrolled population and probably wouldn't be able to enroll because of the RSE status, or the generally on year-long contracts, that we'd work with the employers and work alongside them to get the employees and their families vaccinated. So right on, even before we got the vaccines arrive at the clinic, we approached the employers about the idea of working with them to help vaccinate their workforce, and they were all really, really on board for that, because it was a win-win for not only the organisation, the workers and the community. So really simplistically, we just sent them a plan of our appointments scheduled, and I literally screenshot our appointments and I sent it over in an email, a blank one, and the companies converted that onto an Excel spreadsheet and sent it back completed with anyone who wanted a vaccination within the company. And what that did was it allowed us to do a bit of planning in advance so that we could get NHIs for everybody before they actually arrived. If you haven't done it yourself, sometimes there's a bit of a delay of getting an NHI and getting the person onto the CIR system. So that bit of planning in advance made their visit seamless when they actually arrived. We held dedicated vaccination events for them, specifically for the companies, individually for each company. We did a variety of different settings. We did some Saturday morning sessions where they came in, the entire morning was reserved just for that company and their families. We had reserved sessions through the day so that for a half day or a quarter day, it would just be that company. And we offered some drive-through or drive-in, not specifically drive into the clinic, but the way that our clinic means that they can drive into the car park and up the ambulance ramp. And we had a vaccination station at the top inside the clinic, but we would just go out and vaccinate them in the car and then complete all the CIR inside the clinic, whilst we had someone outside observing them. This was really, really good that they had various options, but by coming in blocks of appointments, they would come down in groups of cars, they would come down in carfuls, they would come down in minibuses, They would all arrive in groups, and it was a really shared experience for them. So they came down with people that they were familiar with, which made the unfamiliar surroundings of a general practice much less scary. They came down together, so they egged each other on. They had fun. It was a real shared experience. To support them, they would bring pastoral care workers with them or key workers with them that, again, they were familiar with. And that was hugely beneficial to us, to help us with the ID and to help with any communication or translation issues that either we or they had. The outcome was that we got fantastic employer support, and most of this was actually done in their work time with the employer's support and encouragement and involvement of the whole workforce. We went in to do some swab testing into one company, and the big TV screen in the kitchen for their lunch break had their COVID stats up there, which were really impressive, and it gave them this idea of, you know, the competitive and how it is to get everybody vaccinated. So even in the workplace, they were seeing that. It was when they came in, it was really positive. They enjoyed it. They would egg each other on, take photographs of each other and with each other, and that was really fun to see. And their vaccination rates in these companies have been 91 to 100% of each of these companies have had their first dose vaccinated, and 70 to 85% of each of these companies has actually vaccinated both doses. It's built stronger relationships with us and the organisations and their workforce, and it's meant that they've been somewhere with their co-workers. They've been somewhere would otherwise be scary. If they now have to come in because they've got a health issue, they're actually less afraid of coming in. They're more at ease. Their last experience went well, and so it's been a real success for us, and has helped them to become vaccinated, which is obviously what everybody wants. That's it. Thank you for your time,
Sarah. So there's just a couple of quick questions there. What is the process of bringing COVID vaccine to the workplace? Can a GP clinic just do so, or is there a separate application process?
Yes, and that's why I was very careful with my wording on drive-throughs or drive-ins. No, we had to keep the vaccine in the clinic, and GP practices cannot go to the workplace. No one can go out to the workplace unless they've been through a separate accreditation process to be able to do that. And that's why instead of going into the workplaces, we brought the workplaces to us, but in specifically reserved times. And for us, we just chosen to stay down that route where they are in the clinic and vaccinated in a safe environment where it's comfortable and we've got the systems working. So that's why we've done it that way. Great.
Okay, so thank you, Sarah. So our next speaker is Mary Losē. She's the Chief Service Experience Officer at Whakarongoroa, Aotearoa, where she leads the cultural service integration of the COVID vaccine Māori Helpline. She's wide-ranging experience in the private and public sector, and she's going to talk about how Māori and Pacific Healthlines can help your vaccination conversation with Māori and Pacific patients.
Kia ora, Bruce. Tēnā koutou kua huihui mai nei, he mihi tēnei kia koutou. Ko Mary Losē tōku ingoa, ko tainui te waka, ko rere ahu ki Ngāti Maniapoto ki Pākehā o ku iwi i te mama, ko tonga tapu ki Mark Haitian i te iwi, ko ki te pāpā hoki, ko harama ki te tautoko i te kaupapa o te Manatū Hauora. Kia ora, good evening everyone. I'm Mary Losē, Chief Customer Experience Officer at Whakarongoroa Aotearoa. You may recall us as Home Care Medical, and these are many services that the organisation operates. I'm sure you're all familiar with them. About 12 months ago, we stood up the COVID welfare unit. So they were the calls from day 3 to day 14 with close contacts in managed isolation. We've since gone on to create the COVID health line and now the vaccination line. So we're supporting COVID in those 3 main areas in the COVID unit. Whakarongoraua has around 2,500 people in it at the moment, and I think I'm being quite conservative in saying we're contacting 15,000 people per day, because our largest day sits around 44,000 during a surge. 1,300 are employed by us, and we recruit the other half through our partnering model. We have 11 partner contact centres, and in October last year we made a deliberate decision as an organisation to start partnering with iwi and to build capability in local areas. So we went up to Ngāpuhi and partnered with them up in Kaikohe. At the moment there are 72 Māori kaimahi, frontline kaimahi on the phones working in our COVID unit. 90% of whānau in that COVID contact centre have never been employed before. Went away from contact centre scripting and created guidelines. We went to our kaimahi and asked them what the experience for whānau might look like, a virtual experience might look like. They're taking the calls, they're the experts, they told us. We designed around that, and we ring-fenced off a workforce of around 145, primarily led out by our Māori partner contact centres. And we ran 4 campaigns for NRHCC actually. So as you can see, just under 17,000 outreach contacts. In the first campaign, we reached out to 5,500, and all of these 4 campaigns are DNA, so Māori who are not engaged in the vaccination program at all. What we realised in our first campaign was the way in which we had approached our own frontline kaimahi, engaging with Māori to serve Māori, placing connection at the centre of the encounter. And we know as service designers that when you centralise design, you place the empowerment of that encounter on your frontline teams. And our Māori kaimahi really enjoyed serving their own communities. Some of the, thematically, some of the narratives that started coming through, or the insights that we started to see that were being shared by Māori to Māori or Pacific to Pacific, community matching we're calling it in our organisation, is that it's not necessarily clinical hesitancy, it is hesitancy around going as an individual. I want to go as my whānau, I'd like to go to a Māori vax site where I feel comfortable. So I think those sentiments had been shared earlier on. Some of the experiences and that were shared by our own advisors are that they felt really great about being themselves, being Māori, whānau to whānau, building trust. So we knew when we were doing away with the contact scripts and creating guidelines that we were placing connection up front. And what we've noticed in the calls is that we're establishing trust, and the wrap up of the call is 17 seconds faster than the average handling time of the non-Māori pathway calls. So the other thing that we've learned too is that Māori, we want to give them optionality. So we started an inbound line. We did no publicity on this. When you call the COVID vaccination line, you'll hear the messaging, you'll wait 5 seconds, and then you'll hear another message that says, we want to provide services for all our communities. If you would like to speak with a Māori advisor, press 1, and you are truncated out to our ring-fenced Māori workforce, and you'll speak with a Māori advisor. Equally so, if you would like to speak with someone from our disability line, press 2, and if you'd like to speak with a Pacific advisor, press 3. So we've built our internal capability and capacity while we've leaned on our partner contact centres, and we're at that point now where we're calling whānau to our line. And on the first day, without any publicity or any push, 279 callers chose to go through to our Māori pathway. In the last 7 days that the service has been operational, we've had 1,448 Māori choosing to go and speak with the Māori advisors, and around 40% conversion rate into bookings. And those bookings are not just individual bookings, they're multi-bookings. So we're booking 6 or 7 people on each call. And again, interesting to note that when you've got that connection, you've got that trust, the business end of the deal happens very quickly. And as I said, 17 seconds faster than a non-Māori call. I think, and it's my own personal opinion, that Māori and Pacific have never been a priority in the health system. So the messaging saying that you're now a priority, you should be getting vaccinated, is met with a high degree of distrust. If you've never been a priority before and now you are, it is a very foreign concept for Māori and Pacific. That is what we're hearing on the phones, and certainly what our whānau are telling us. In terms of community matching in our organisation, we already do this with Māori to Māori, Pacific to Pacific. We try and get as local as possible with our contact centres up in Kaikoura. If we've got a caller calling us from Moirua or somewhere up north, we try and match them community to community because of that local knowledge. They'll know where the vac sites are. They'll be able to determine the busy times or wherever. We heard a lot of stories coming back on our lines where whānau had called, they'd booked into a site that was literally an hour away for them. So it's just unmanageable to be able to get to that vac site. But with localised knowledge, we're able to serve our communities a lot better. So these are some of the stories that are coming back through. And, you know, a lot of Māori have told us that they thought the vaccination wasn't for them. And again, I think that comes back to the point around not being a priority, just don't trust it at all. So that is what we're doing at Whakarongora Aotearoa. And there is a story on stuff.co.nz around the Māori pathway and the establishment of it. We are looking to mirror something in our Pacific space as well. Kia ora, thank you for your time.
Okay, Mary. Well, it sounds like you're doing great work there, and I hope you write this up somewhere. This is the academic part of me, because it seems like you've learned a lot that would be of great use to us with the whole health system going forward. You really, you came up with some great ones there. Somebody just did ask, what's the 0800 number for the COVID line?
I'll put it in the chat.
Okay, that'll be good. Okay. Okay, sorry I missed how whānau can engage with this service, and does it extend all over Aotearoa?
Yes.
Yep. Okay, good, good.
We're a national service.
Yep. So national service, fabulous. Perhaps just take a few questions. I think some of these would be for you, Matt. There was a question there about from Richard, query builders can be as tricky as the virus. Would be helpful if Goodfellow could make available a validated medtech query to identify Maori Pacific patients who have not yet had the first dose. Do you want to unmute and perhaps take that, Matt, while we wait for Sarah?
Yeah, look, I appreciate that. I can't talk on behalf of the Goodfellow, but the PHOs get regular data feeds around vaccination, and I understand they've got processes for getting that in. I think we can absolutely, you know, take that away. I think there's work nationally on how CIR integrates into other systems as well. So, look, I'm happy to take that as an action and see if there's something that can be done.
I think that would be great. It would certainly make practices, you know, sort of autonomous. So thank you for the question, Richard. A few other questions there. One is, how does the public know which general practice is participating in Super Saturday Shot for COVID? I don't see a published list. I guess you're building it up at the moment.
Yeah, we will. So we're just getting information back from practices at the moment. We've had a really strong response. We just obviously sent a bit more information about the support, the $1,000 that's contribution that's going in as well. So just waiting to see and firm up that list, I think, as we move into tomorrow, and then we'll be pushing out lots of information online. So there really is going to be a lot of stuff happening with the Vaxathon. There'll be stuff on Māori TV. There'll be coverage on TVNZ1, on 3. I think there's going to be something in Shortland Street. So it's going to be everywhere, and there'll be lots of information pushed out.
I understand the vaccine payment is at the after hours rate. Is that right?
Yeah, because it's a Saturday. That's absolutely right. So okay. The $1,000 is a contribution, just recognising that Saturday isn't necessarily a normal opening time, and then, as you say, any vaccines administered on the day would attract the after hours rate.
Is there any option? Our clinic would be interested in opening for 4 hours, not 8 hours, because that's quite a demand with people having to come back on the Monday. And we've actually asked, could we open for a shorter period of time?
Yeah, that's a very good question, Bruce. We have had a few comments back on that. So at the moment, the funding packages for the day, it's been set nationally. So look, we will take that as a way, but at the moment it is for opening on the day. And I think really it was about just creating as much capacity as we can on that day and trying to have a record-breaking vaccination day.
Yep, fair enough. Statistics presented by Matt, why are Fijians excluded from the Pacific umbrella and grouped in with Europeans?
Yeah, look, it's a tricky little one. Fijian, Indian. So we don't necessarily get it broken down at a secondary or third level. So it's hard to understand what's happening a sort of a detailed level. So because of that, some of the issues with the data, we've just had to group it that way.
Okay. We'll move on to Cherie now. Hi, Cherie. You're going to present now, so thank you very much. You're from ProCare.
From ProCare, correct.
Okay, over to you.
Kia ora koutou, everyone. And I'm just going to give a super quick update of where we are from a PHO point of view after our 8-month process of onboarding practices. And I'm pleased to say ProCare now has 84 live COVID vaccinating practices. So I do want to mention that the onboarding process I'm referring to is for Auckland Metro DHB practices, and we are aware that different DHB regions have differing requirements. So the key thing that I want to mention or highlight on this slide is that onboarding is now flexible enough to fit any size practice and workforce. Yes, there's still compliance with the documentation to complete, and some practices spend quite a bit of time with their CIR training, getting business domain email addresses, then keeping up with the CIR access, lockout, resets, etc., before they're live and operating normally, and there is a CIR learning curve. However, the biggest difference for our practice onboarding has come about because since July, the PHO has been completing the QA accreditation processes, and that now includes a more streamlined SOP document that takes into consideration the practice foundation standards achievement. And I also want to note that the car park and outreach models of vaccination have proven very popular for some practices, and they're easily obtainable at the time of the QA assessment, or what we call the wet run. So recently, Auckland PHOs have received access to current CIR data, and this has given us the opportunity to provide reports to practices on their vaccinated and unvaccinated populations. Practices can now download priority lists of Maori Pacific patients for phone call projects, for example. And our own PHO phone calling has targeted practices with the largest number of Maori and Pacific patients and has yielded mixed but beneficial results. So 40% of those offered vaccinations have accepted. However, that cohort group's only been about 15% of the total calls made due to other connection and data issues. However, the work continues, and we look forward to seeing the results from funded calls. So there's now funding available for proactive, in-depth GP phone calls to Maori and Pacific patients who have not yet booked for a first vaccination. This is on trial for the next 2 weeks before we hope possibly being reviewed to include nurse practitioner or nurses in the funding scheme. It's important to note that supporting documentation of the GP conversation needs to be included in the claim process. Home-based vaccinations are also now funded, only for those practices that are already vaccinating and have been accredited for outreach activities. This is a PHO managed process, and there are clear guidelines for practices to follow. The practice completes the claiming process to POAC for both types of funding through their PMS e-referral form. For those practices with PMS systems who do not use e-referrals, manual invoice claims need to be made directly via email to POAC. And in wrap-up of this update, I'd like to acknowledge that there's been a lot of hard mahi from general practice teams to get up and running with COVID vaccinations, and we thank all the teams for their dedication to this work. So thanks, and back to you, Bruce.
Sorry, Cherie, I forgot to introduce you. You're the quality manager for ProCare, and you normally work on Cornerstone and Foundation. So this has been quite new and fresh for you. So
a bit on a dime. Yep.
Yep. Okay, and thank you for your comments about the hard work that primary care has been doing. And I'm delighted that nurse practitioners and nurses may be included because we've got a bunch of them at our clinic.
Right.
So
yeah.
We're very keen on nurses and nurse practitioners. So, so thank you very much. So our next speaker is Lindsay Haven. Lindsay is the Northern Regional Health Coordination Centre vaccination coordinator. She's been helping GPs and pharmacies get up to speed with Book My Vaccine, and she'll share her tips about how to manage that.
Kia ora, Bruce, thanks for that. Kia ora koutou, everyone. Just a minute while I share my screen with everyone. Myself and the team here at the NRHCC, we've been working to help practices and pharmacies get on board with Book My Vaccine, and I'm happy to say that we now have 179 primary care sites in the Auckland region using Book My Vaccine, helping to improve consumer visibility of your site. Book My Vaccine sends confirmation and reminders automatically, and your appointments booked in Book My Vaccine will automatically appear in CIR. So we have some experience here with 179 sites, so we've got a few recommendations if you're interested or thinking about coming on Book My Vaccine. So probably the first and best thing to set up is a consistent schedule of Book My Vaccine. It's not quite as flexible as your practice management system templates, so it's a good idea to establish kind of a dedicated vaccinating times and days and keep it consistent. 10 or 15-minute slots are ideal for Book My Vaccine. That allows good patient flow through your site while still allowing a bit of flexibility to adjust your capacities. And please, if you're using Book My Vaccine, access the additional reporting via your NIBS concierge. From there, you can see booking information like mobile numbers, and sites have found that really useful to help with DNAs. Like Siobhan mentioned, confirming appointments, following up on missed appointments, identifying those that might be hesitant and making a plan with them to get them back into your site, and encouraging and making those second dose bookings. So please, if you do have any questions about where or how to access that reporting from Book My Vaccine, just reach out to my team and we'll be able to give you a hand with that. If you're still not sure or have any other questions, we're available here at the NRHCC through the NRHCC support email, or your Metro Pharmacy COVID-19 box, which I'm sure all the pharmacies are familiar with. So I think that's probably the top tips from me, Bruce. So if there are no other questions, then can hand that back to you.
Thank you. Good to see pharmacies involved in this. So thank you very much, Lindsay. So our next speaker is Sara Hartnall. So she's an urgent care physician working with the Northern NRHCC.
Kia ora, Bruce.
Kia ora, Sarah. We've got some questions there. If I can just, okay, so GP practices don't want to waste unused shots. Then should health professionals be allowed to use them up for a third booster? It's now 6 months after the second dose for most essential workers. So what would you say to that? Do you waste it or use it?
Good question. Just a little disclaimer first of all, as you say, I'm an urgent care physician by training. I'm the clinical operations lead at the NRHCC across the vaccination program. So I have learnt a lot about vaccinations. I'm not an immunologist, but as I say, I've learnt a lot. So that's kind of just the caveat in terms of who I am and what I do. The third dose question is starting to come up a lot. The National Clinical Advisory Group are actively considering that on a routine basis and are sort of just continuing to evaluate the data. They haven't made a decision yet about third doses. So I guess it's sort of a watch and wait. Technically, third doses are not authorised at the moment under the MedSafe approval. So any third doses would need to be given under Section 29 of the Medicines Act, and it's not something that we're recommending at this stage.
Okay, so how would you convince a patient who's hesitant due to her previous history of Stephen-Johnson syndrome after some medicine? We're getting the tough ones tonight.
So again, I think there are actually very, very few contraindications to the vaccination. I think probably our earlier speaker, Jessica had some really great tips about, speaking to people about their reasons for not wanting to be vaccinated, and really sort of like engaging them and working through that with them. It's not a contraindication at all in terms of the clinical medicine. It's really about the connections.
And any tips for dealing with abusive and angry patients when we bring up COVID vaccine?
Again, good question. I think from a communications perspective, you, Bruce, in particular, have a lot of experience with that. I'm not sure if you remember, I was your registrar a very, very long time ago.
I did, and a very good one too. Okay, no, I think you just have to sort of apologise and look humble, eat humble pie. So I've got that very situation with a patient of mine that I'm working with, and I've tried my strategy of begging him and told him I don't want to lose him, and we're making some progress. So he's sending me email questionnaires, and he got me to watch a video, and I watched the video, which was a pretty good video, except at the end it went on about vitamin D and ivermectin, and I said, well, at that point I lost faith in the quality of the speakers. But they had some reasonable questions about the vaccine that I hadn't thought about. So we don't have all the answers, even if we've been pretty up with this. What do you tell patients with fibromyalgia who refuse COVID vaccine as they heard it worsens the fibromyalgia?
Yeah, again, it's connecting with people's hesitations and really trying to help them through it. There isn't a contraindication for fibromyalgia and vaccination with the COVID vaccine. So again, it's just connecting and working through it and helping them across the line. And the tips from the earlier speakers, I just thought were really fantastic. So I'd encourage you to sort of have a look at that document. There was a meetings recently about the GP conversation where that document was attached, and I really encourage you to read it. It's a really great resource.
Question there about if third doses are coming, what about checking antibody levels? My understanding is we can't check antibody levels at the moment in New Zealand, publicly or privately.
So antibody testing at the moment isn't thought to be very useful. Really just because there hasn't been a sort of an internationally recognised or agreed correlate in terms of what is immunity and what equals immunity in terms of levels. So yeah, it's certainly not something that we're, as you say, able to check from a primary care perspective or recommending.
What about anti-vax comments on social media? Engage or not? Will they convince others who are sitting on the fence? Or should we comment to balance the arguments?
Yeah, that's a really hard one. I struggle daily, and sometimes I bite my tongue, and sometimes I give it a try. I really liked the avoid the fact off comment from, I think it was Jessica, our first speaker. She hit the nail on the head, and I think really kind of going head to head and sort of doing well, I know the facts better than you, it leads to resistance, and rather than good quality engagement. So, and again, just coming from a place of caring, I think is really helpful. Yep.
One of the docs or solutionist has said she did check antibodies through lab tests, $112. News to me. Did you know that?
I did not know, but it's certainly not a useful test. So I wouldn't encourage you to use it.
Yep. Okay. Would you recommend patients to take Panadol or Brufen prior to vaccines?
I wouldn't. I know that there's sort of been kind of trends for either way. I think that if they experience, the flu-like sort of muscle aches and pains and things after vaccination, sure, but I wouldn't routinely recommend it, no.
Okay, got quite a long question here. Our practice is currently working through these lists and have multiple patients who have been vaccinated overseas and may still be caught up overseas. How do we update the information via CAR when we don't have access, as we are not a COVID vaccinating practice? If we are able to update the CAR, then these people continue to show as overdue when in fact they are not, does not reflect accurate numbers vaccinated throughout Auckland.
That's a really, really good question and a good point. I am awaiting the answer from the ministry in terms of my question, that exact same question that I've asked the ministry. So it's they are sort of considering it as a national response. It's a really good point. We've got lots of people who've been vaccinated overseas, and we want to be able to recognise those vaccinations in the CIR. We're just awaiting advice on how we're going to do that.
Okay, just a question about equity here. Should we be doing third doses given the global vaccine inequity? Should New Zealand be reaching out to Pacific nations first to aid with full vaccination?
So that is a really good question. And I think you could also ask it from a New Zealand perspective, you know, how can we offer third doses for people when we haven't actually vaccinated everybody for their first and second? So it's a question. In terms of the Pacific, we do have a responsibility to our Pacific neighbours. I'm not clear on what's happening at a national level in terms of what the support is planning to be or has been to our neighbours. I do know we're starting to vaccinate mariners who are on the Pacific shipping route to protect the Pacific neighbours.
So a question, and this might be more for Matt, I'm just not sure, this is more a system issue. Kia ora whānau, my question from recent clinical experience in South Auckland, we're a lead primary care provider, not been informed of patients who are COVID positive being admitted to MIQ and discharged. Bit concerned about the many who will quickly fall between the gaps of the system. Yeah,
I believe that has been an issue, and it's really just about communications, really, and making sure that the I's are dotted and the T's are crossed in terms of when people are discharged from MIQ. The outbreak and testing team are across this workspace, so apologies, I don't have a lot of information, but I know that is understood to be an issue that they're working through.
Any final comments from you, Matt? I think you and Sarah have got the floor at the moment. Any comments?
Well, look, I just wanted to, on behalf of the NRHCC and Elsa as the lead CEO, just acknowledge all of the speakers tonight. It's been, I hope others have enjoyed it. I've found it very interesting, and I just want to acknowledge all the incredible work that goes on every day, and Mary with Whakarongaro and the great work that's going on every day there to engage with the community and really get people vaccinated. And I think, yeah, just really trying to throw ourselves behind Saturday and see what we can do there. And I think we can have a bit of fun and get people excited and engaged in the process who might not otherwise have been. I think it's all really good. I think we're absolutely committed in Auckland to getting every person vaccinated who we can. Yeah, trying to, take back a bit of control.
So thank you very much, everybody. Thank you for the team. I think it's been a fabulous night. We've got through all the questions, which is great. So people have stayed on till the end, and that's always a good sign. So thank you very much and good night.